Welcome to Strata Office Hours. My name is Thomas Schreiber. I'm the Director of Marketing here at Strata. Strata is a single EMR platform and revenue cycle management service for physical, occupational, and speech therapy practices that helps you achieve a 99.99% reimbursement rate. On today's Office Hours, we're joined by Justin Stiver and Ben Galin. Justin is the owner of Total Therapy Florida and grew the practice from 1 to now 7 clinics across Florida. Ben is the owner of Evolution Rehab Group and has spent more than 30 years in the PT world. Justin and Ben dive deep into the various ways to increase reimbursement rates, including how to renegotiate contracts with payers. If you'd like to learn more about Strata and see how our EMR and RCM works, head over to stratapt.com to book a demo. Now, without further delay, here's today's Office Hours. Kick it! Can you share some just tactics for everyone here on how you would go about increasing reimbursement rate? What are some of those foundational things that you got to have in place, then maybe something a little bit more advanced?
Well, I think if you look at reimbursement rates, and to be clear, disclaimer, I'm not telling anyone that the way we did it is the best way to do it. It's kind of been one of those things that we did what we thought was best, and then we looked back and kept on doing what we think's best. Now we're here now, and but I think it's important to understand what goes into reimbursement rates. So you have the total net revenue per visit, which is really what matters to us at the end. And then you have to go backwards, and there's a lot that goes into that. So your revenue per visit is contingent on how what that specific payer is paying you, but it's also contingent on how many specific units you bill, what CPT codes you bill, and that's just on the revenue side. On the expense side, then you have what you're paying your therapist, you have what your overhead is, and any one of those can be manipulated in order to make that net revenue per visit number be what you need it to be. We decided that it didn't make sense for us as we started to grow our brand to be accepting a payment for services that was less than what it cost us to operate. And I'll tell you, it's not easy for a lot of clinics to actually figure out what it costs them to operate. I mean, you could take how much your expenses are over, what overall visits, but you have to understand that where you're at in your business at the time, that those numbers can be totally skewed. If you're starting up a new clinic, those numbers are going to be super high. So we've grown from only one clinic in 2018 to now we have eight offices now. So it's we were growing, so it's really hard to tell where you're at any office. So now that we have more data, it's a lot easier. But we're on a 3 or 4 week wait with Medicare payers that were paying us about $108 per visit, and then we're accepting $50 per visit rates. So it didn't make sense to us to do that. But I think you really have to figure out your numbers, and then you can go from there. So just like almost raise a hands. I mean, who knows their expenses per visit number like really well? Like right now, you could tell me what it costs you to deliver one visit.
Yeah, feel free to raise your hand or use the digital raise hand in the bottom there.
So most people don't know that. They think they know, and but they're reading insurance contracts to sign, and they're accepting reimbursement rates. I think just kind of hoping that if you can get yourself busier, that you're going to be able to make more money. But you can certainly make more revenue, but it doesn't always equate to more profit. So our company's expenses per visit is $81 per visit. It costs us $81. And from that $81, I know what of that is in the marketing business, the development side. I know what is the payroll side, and and I know every expense percentage of that number broken into that. So if I want to manipulate that, let's still like this year, my goal is to get that down to $78 per visit. And you can do that by having less expenses or growing more visits. But I think it's, if you don't know that number, it's really tough to decide what contracts you should take, what patients you should accept, what rates you should set. So I would love to hear you guys explain to me what your thought process is going into this too.
Yeah, one question from Roy, Justin, was at what level of forecast utilization is that 81 number based upon? And Roy, feel free to go off mute and maybe add more to that for Justin.
Certainly. Thank you. So our clinicians are modeled out at 11.5 average visits per 8-hour workday. That's how we model and forecast. So are you basing your costs on a number similar to that, or you're basing your costs on 100% utilization or something less?
I'm basing that number off what has happened historically. So not what I'm thinking will happen. I'm just looking, I'm looking back at that number, and I'm doing that every month, every quarter, every year.
Yeah.
I'm seeing trends on how that's happening. So I can forecast numbers, but what's more important to me is looking back. What did we do last quarter? And what did those, because those are actual expenses,
Yeah, I get that, but we're a new clinic. We're only open a couple of months in this new facility. So we're growing 20% a month. So it's difficult to say, so our fixed costs are our fixed costs, obviously. So, but if I'm using cost per visit, I have to give an attribution of that cost, to that visit. So I guess I can just use an average forecast, but that's the question.
Yeah. And that's something, is this your first clinic or is this?
It is first.
Yeah. I would say that's a very difficult number to look at, knowing what you're going to do. But I think you have to set goals on what you think you can do, and then very routinely go back and actually look at those numbers to make sure you're hitting those targets also.
Every day. Thank you.
Yeah.
Is anyone here has anyone in the past, in their current life or past lives or past clinics, successfully negotiated with an insurance company to actually change your rates for the better? You're able to. I would say I echo 100% what Justin said, that if you imagine that you've got this line graph or bar graph, and this is my total expenses, this portion's payroll, this portion is administrative staff, this is my clinic overhead, this is my consumables, this is my cost of customer acquisition, etc. And like you said, if you want to squeeze the whole thing, the question is, does everything get reduced by 5%, or can one area get reduced by 10%? So I wholeheartedly agree there. I would say a real. I mean, let's exclude Optum, but a real thing that you can do is negotiate with payers, especially local payers, especially the Blues, because they're hyper local. And the idea is, if you collect data, especially if you use Promise or if you use something that's like true data, and you collect data, and you're beginning with the end in mind, and the goal is, I need to present to this payer that I do things better, more efficiently, more effectively, and for less cost. And you're going into it with this idea in mind, is I'm not going to squeeze every penny out of every visit. I'm going to go in the mindset that I can collect enough data on cohorts of patients, which might be all patients, which is tougher to do. And I'll explain why in a second, but it could be on specific subsets, all total joints or all knees or all hips or all whatever. But you can say, I'll take all patients in Florida Blue. And you can say, I want to look at my actual length of stay, total cost of care, and initial outcome measures versus final outcome measures, satisfaction scores. And you truly make a commitment that I'm going to collect this data come hell or high water. I need to have this data. And if you get this data and you go to the insurance company, because they are, the one thing I'll tell you is payers are very data savvy. In fact, their entire business is run on data. They're as unemotional as it can come. And they'll say, if you come to me with good data, let's talk. If you come to me with this, we're just a great clinic, like you're not going to even get in the front door. But if you come to me and say, I know that our average cost of delivering treatment is $796.43. And we have at least a 74% improvement in functional outcome scores with everyone, 95% of our patients being discharged with a outcome measure that has at least a 20% impact to their life or less. And blah, you have that level of data and you go, and therefore, I want to negotiate my rates a little bit. You'd be surprised how many of these companies have tiered rates where it's already known and it's already like they don't have to go back to some board to figure this out. They go, okay, you qualify for our higher tier rate because wow, like you are a value-based minded provider. And they'll then say, now, and again, this isn't going to change your gross top line revenue because you're probably going to end up doing a little bit less visits, etc. But at the end of it, they're going to say, going back to Justin's point, I can increase your per visit rate though, because at the end of the day, I know that you're stopping downstream spend. And it could be something like data points are timeliness of care. I'll get all of your patients in within 24 hours. That's a big deal to them because they do know that the longer you delay the start of care, that the more expensive that patient's going to be. They have data that shows that. Coordination of care. I mean, there's a lot of little stupid things like if it's an insurance company that controls their own pharmacy benefit, you might go, hey, we're in PT. What does pharmacy benefit have to do with me? The answer is it doesn't. But it does because if you say, I get 50% of my patients to go on to mail order pharmacy benefit. And again, this sounds so crazy, but it's a real story that I've been involved in. For an insurance company that does have their own mail order pharmacy benefit, because they own it, for every patient to go onto that compared to going to CVS or Walgreens and fill in their prescription, it's something like each 0.1% of people they could get onto their mail order pharmacy saves the system something like $10 million. And so you can imagine if you say, hey, I see 1,000 of your patients a month and I'm going to get 500 of them to switch to mail order as part of your negotiation tactics. It sounds stupid, but it's something where they'll go, heck, if you could do that, like, let's talk about rates because you're making and saving me so much money over here. If I have to give you 10 more bucks per visit to get that, and you're going, why would I ever think of that? You wouldn't. But if you go into these meetings going, I'm engaged and trusted by your patients, and I see a lot of them. Is there a pain point you have that may be semi-related or semi-tangential? And you go into asking those kind of questions, you'd be shocked at the things they say. And like I went into one with Geisinger a while ago, and this is from Geisinger, who said, our biggest thing is getting patients onto mail order pharmacy. And I said, what if we have a KPI that I guarantee will get a certain percentage of your people on a mail order pharmacy? And they wanted to guarantee only 5%. I could get 5% of the patients I was consulting with a group at the time, get 5% of their patients on a mail order pharmacy. Geisinger was willing to increase the rates by significant dollars because that meant something in the neighborhood of like $20 million a year to them. So knowing your data is huge. Collecting, knowing, controlling your data and presenting it to the right payers. Is Optum going to care? I'll tell you right out, no, they're not going to care. There's just no wiggle room with Optum from anything I've seen. So I'm not going to pretend that they're there to play. But I would tell you, your Blues, some Cigna, especially self-funded employer plans, you can affect your rates more so than you think, but it's going to take a concerted effort of not only collecting that data, but delivering care in a methodology where you're going, I need to be really cost effective in delivering this care for the bigger future of getting more dollars per visit.
So I'm in the process right now of, in Florida, Blue Cross Blue Shield is a closed network in our area, I should say. And so we have a weird situation where one of our offices is in network with Florida Blue and the other ones are not. And it's confusing to the patients, and all the physicians referring to us are like, what do you mean they have to go to your Osprey office to be in network? And we explain it to them and they think we're lying because it sounds crazy. But so we were at the point where we were our numbers were telling us that we should drop Blue Cross Blue Shield, and we had a plan to do that. A business development team and everybody had this plan. And when I went to Blue Cross Blue Shield last week and said, I want to talk to you about terminating this contract, then all of a sudden the negotiation doors opened And we're in talks right now where all of a sudden now they say, yeah, we'll let all your clinics in. You just have to, yeah, that's fine. I've been trying to do that for 4 years and I couldn't even find someone to take my call, you know? So sometimes it's harder to get the right person on the phone. And that's one of the most frustrating things that I dealt with as a startup new owner was, okay, you guys talk about negotiating these contracts. How do I get the right person on the phone? Because either they're not with the company anymore. My last contact that helped me out last time isn't there anymore, or is in a different position. No one returns our emails. You call the CSR, you know. So I'd say consistency is key. Just keep hammering and asking people who's the right person to talk to. Use that relentless resourcefulness attitude and try and figure it out, get someone on the phone. But also, they were very responsive to our data. I said, look, this is how much we're getting paid per visit and everything else. And also, you know, I went on the Strata benchmarks page and I found average reimbursements for payers for other states and everything else. And having that conversation, obviously being respectful and saying like, look, I just want to be treated fairly. And here's what our costs are. And here's, you know, and also I went around and I went to 70 different physicians that refer to us. And I got them all to sign a petition to allow us back in network with Florida Blue for all locations because it's affecting their patients. They want their patients to come to our company because we know their post-op protocols and they trust us, and their patients are being told no, and it's very frustrating and it's affecting their care. I got all those physicians to actually sign this paper, and they took me very seriously after that, you know. And then the other thing that I did was I said, by the way, I'm getting paid 37% more out of network than I am in network. You know, how do you believe that to be fair? You know, and you start asking the right questions and doors open. So I definitely think that it's something that you should be doing all the time. And I think with Blue, it was after 1 year of your first contract. After 1 year, you can renegotiate that contract again. So
yeah. So we got a couple questions here from Blaine, Roy, and Luann. I know you had your hand raised. Blaine, let's start with you. Any other? Do we cover your question? Feel free to chime in there. I just want to make sure we covered that.
He did answer it, but I do have another one.
Yeah, go ahead.
Is it possible that after having a conversation with the insurance company that they might lower your rate? Like, let's say it's not for a good conversation for some reason.
No,
like, is there ever a chance that it would negatively affect it having that?
I have literally I've been in a physical presence of Highmark, walked out their door, and probably muttered some stuff I shouldn't have muttered, and still not had a negative impact on them, like retaliatory doing stuff. So I would say on an end of maybe, let's just say 70. I've had some bad meetings. I've never seen that. I've never seen like I said, they're really unemotional. It's just, and they're not even like mean, or just data. And to Justin's point, especially if you get to like a hyper local market, you get to like the local market president or someone who's in charge of member customer satisfaction kind of stuff. Like they are bonused on like how happy their members are, how much, like, accessibility is a big keyword. Like I've only had a handful, like under 5 adversarial meetings, Optum being one. Like, you know, that I'm just convinced that there's just no doing anything with Optum ever. Even if you're like, hey, I'll cut your costs in half, I don't think they'll care. But no, I can't foresee a reason why, and knowing some of the inner workings of these health plans, I can't see a reason why someone go, that jerk Blaine came and asked for more money, I'll show him, we'll slash him by 50% kind of thing. I mean, I've publicly went on a rant against Align Networks and started a little bit of war with them. And, you know, at that point, maybe 30% of my business was Align, and they never even threatened to like slash my rates or anything like that. Like I would say that's highly improbable.
Yeah, but we should be leaning on those. I mean, I think as we can't collaborate. We can't break any federal laws by saying we should all do this together. But I think it's important that you fight for yourself and every other. For some reason, the PT industry has always just kind of taken a back seat and let things unfold, and not been a great strong advocate for themselves. But off of this conversation, and I'm happy to stay on this conversation if you guys want to, but we have to also understand that a lot of the dollars that we get are that we can control too. And when I started my company, I realized that most PTs, when they join us, because we started with 3 physical therapists, now we're up to 37. So I've trained and hired a lot of PTs in the last 5 years, and I realized that most of them don't know how to bill, they don't know how to code. There's inconsistencies, terrible inconsistencies, and if I would say I've yet to hire a single PT where I could say, can you tell me off of your memory what Medicare's definition of therapeutic activity is versus, and will you tell me the difference between a therapeutic activity and a therapeutic exercise? And I have not had one person get that question right or confidently knock it out of the park. They all don't know, and by the way, they're very appreciative when you educate them on it. As practice owners, we have to be very careful not to make it sound like we're just trying to get more money out of them. But at the same time, you have to explain to them that ignorantly underbilling is the same thing as overbilling. It's still coding improperly, and we should be billing for what we do. And since that happened, and when we started having these conversations, we went from, as a company, we were billing about 3% therapeutic activity. Now we're over 40% therapeutic activity, and the difference in the reimbursement per visit is giant. And also, even just knowing what insurances you can bill a 5th unit on, or AMA billing versus Medicare billing. I mean, that's, again, most therapists don't know that. And if you go back and start looking at your claims that process through, you'll start seeing that your notes. I see it all the time, and we do a great job, but it still happens. So if you're not doing this, I bet you it's happening rampantly. But they'll bill for Medicare's 8-minute rule, and they'll charge them for Medicare. But it's an AMA plan, and you didn't have to use Medicare's 8-minute rule. You could have built an extra unit in less time based on your minutes. You just picked the wrong code, and that's something that if that's happening, then it's just revenue going out the door.
Yeah. Blaine, we'll come right back to that question. Luann, do you want to chime in and just ask your question to Justin and Ben, and then Roy, we'll get to you.
Actually, mine was answered.
Perfect. Awesome. And then Roy, if you want to just chime in, I know you had 2 questions there.
Yeah. So Ben, the data that I continue to capture is visits per discharge. We're collecting the functional outcomes. We're doing 2 to 3 surveys per each plan of care. We're doing exit surveys from a patient perspective. We're doing exit surveys from a doctor perspective. So I'm collecting data as much as possible. I'd really like to understand from you where you find the KPIs to be most effective. What are those offbeat KPIs that you used effectively? Because I had, pharmacy benefit, wonderful, never heard of it before. Coordination of care, help me understand that. Certainly the functional outcomes I understand, but I'd like to hear more about those offbeat KPIs that provide leverage and asymmetric negotiation.
The reality is the offbeat ones are going to come from discovery conversations, because even like what matters to a group at the moment changes almost season by season. Like there's like Texas Blue, I could tell you right now, if you wanted to talk to them, anything cardiac related, they're all ears. If you talk to them, anything not cardiac related, they don't want to talk to you. Like, there's some directive right there that they've got something going on with their cardiac care. So but a year ago, that wasn't the case. So I don't think there's like a blanket thing to say, these are the offbeat things that's going to make this person excited. I think it's more of a conversation. Is like you're collecting great stuff and you're starting to present that, but you say, like, what are pain points for your organization as a whole, knowing that I have a captive audience of your members? What's a pain point? And you could say, like, is mail-in pharmacy. Like you could just start like, is that something that you consider? Is closed loop referrals something that you measure? Is there something that's a pain point for you? Is it getting people to do adult wellness visits? Is it, you start just asking, is there some pain points that may not be directly related to the fact that I'm a physical therapist or physical therapy clinic, but is there something related to the fact that I look at me as a care navigation, care coordination, care management? I'm in front of a lot of patients and have a lot of their attention. Is there something I could be doing that helps you out? That doesn't necessarily help me out, but that helps you out. And I'll give you another example is I do a lot of work with an at-risk ACO. And one of the things that they get nailed for is not doing proper screening. And a couple of the screenings are, tobacco, alcohol, fall risk, whatever. So on 100% of my evaluations, we capture those, beyond what I'd normally capture for physical therapy evaluation. We're capturing some data sets for them because they know that push comes to shove and they get audited. Like in their computer system, they know that if they referred it to me, it's checking off that those measures were done. And they know if they get audited, I'm not sending them back to them. They know that I'm collecting them, keeping them in the chart, and if they have to get them, they'll get them. So that was something really big to them to cement my relationship to get referrals from this at-risk primary group is I will collect, on my intake, I'm gonna have 3 pages of stuff. They're already filling out 5 pages of stuff. I'm gonna include 3 pages of stuff on your patients so that you could count on the fact that you referred them to me. Home safety assessments, one thing we do for them. Fall risk kind of associated with that. There's a high risk medication screening we do. And I think substance abuse is something we do. And they just know that if they send it to us in their EMR, there's essentially a quality control checkboxes. If they sent us it, boom, they're checking it off that it went through. That same group, part of their STAR measures was closing the loop of referrals through electronic means, meaning like direct messaging. If I could direct message them back the order, even if I do it once a quarter, then they could check off that they do direct messaging, alternative means of closing the loop. When you talk to people and just finding out what their pain points are, it's like, hey, it might take me a minute more, a little bit more, but if that means opening the floodgates to patients or changing your rates, it's something you shouldn't discount.
Yeah, and I'm not having, as was mentioned earlier by the other speaker, I'm not having discussions. I'm not getting people on the phone. I need to create a pattern that helps me break through that barrier and get them on the phone. So perhaps because we are doing these screens already.
I applaud you.
Identifying that in that email probably is not a bad idea.
Yeah.
I found like becoming like a little bit more intimate with the people involved. And there's geographic conferences, geographic meetings you can go to. I mean, there's national ones like AHIP, but there's geographic ones you can go to. And it's like a gathering of benefit brokers and insurance plans. But like, one guy who oversees most of Florida for Florida Blue, this guy named Phil Lee. I got literally like stuck in an elevator with him once at a conference and we talked a bunch and his kids plays baseball. And like struck up a conversation. Now all of a sudden you have this ally, but I'm not saying go get stuck in an elevator with someone. I'm saying go on LinkedIn and stalk this person, find out who your regional people are and see one thing you have in common. Oh, we both went to James Madison. Awesome. I'm going to start texting like, hey, did you see the JMU game last night? We're so excited that they, made it to the tournament, and just get a tad bit friendly with them. And all of a sudden, like, well, who are you? What do you do? But I think just cold calling an insurance company, I've never had success just like cold calling an insurance company. I've made relationships and contacts either going through larger groups and getting introduced, or going to conferences and meeting people, going to local stuff and meeting people, or again, just kind of cyber stalking people and making it so they understand that I'm a human that exists and I want to talk, get friends first and then talk later. But I don't think you're going to be ultimately successful just cold calling an insurance.
Well, certainly we're trying many different things, but you had mentioned local and regional conferences. Could you give me one regional conference that you believe would be a good place for me to start? I'm in North Carolina. If
AHIP is anywhere near you guys, AHIP is a great conference to talk to plan leaders. I mean, fantastic conference. I don't know if AHIP's in care. AHIP has a national conference and there's locals. But I've kind of, because some of my other hats I wear, I do go to a lot of these conferences. Let me offline start scouring to see which ones are North Carolina. I can tell you, things are regional, and when regional, I'll say like Southeast, and Southeast, they'll say Virginia through Florida through Louisiana as like Southeast.
Right.
Not often is it like just the state of Carolina. But that being said, like, Carolina Blues, I'm sure have stuff going on a local basis. Like I know Merge Ortho and Ortho Carolina just combined together to create an accountable care entity called the Hive, I think, the Hive of the Carolinas. And they did that in cooperation with Blue by talking to Blue over and over again, meeting them at the conferences. So I'll look offline to see if I can find some stuff locally for Carolina.
Perfect. Thanks.
I have a question. Ben, have you heard of anybody using the APTA's new study, the value of PT, economic value of physical therapy? Have you heard of anyone using that successfully in their
Not
discussion?
yet. I think it was still kind of, it's less than a year old of being published, and I think it kind of still smells new. But I was begging, I was so hoping the APTA would publish something like that 10 years ago, 20 years ago. No, but I would highly encourage that being part of an arsenal of talking to an insurance company. It's very validated, peer-reviewed kind of stuff that's hard to ignore.
Has everybody seen that article come out?
I think Justin, check the chat. I think I linked the correct one,
Yeah,
but
they
you
published it in, I think, May or June of last year.
It says, it's if you go to www.valueofpt.com, it's the APTA's.
It talks about things like, for example, like PT first versus carpal tunnel surgery, or even like pelvic floor surgery versus PT, and the savings. I think we talked about this in one of our last meeting. Like my biggest thing is I don't like competing with other practices or ourselves to go, I can name that tune in less dollars. I like saying, like, I've used this before, is like, I am your value-based option. Like, why should I be paid? Why should I be competing to say, oh, I'll slash $2 off a unit? Or, when Align or Occam goes, hey, your neighbors are taking $48 a visit, will you take 46? And I keep on saying, I already am your value-based option. Like, you should be comparing me to surgery and sham procedures and visco supplement injections. Don't compare me to other therapists. Compare me to the alternative. If this person didn't come to therapy, boy, are they going to be costing you a whole lot of money. So that tool set that the APTA has published is definitely a great tool set. And I use that in presentations in some of my other companies when I start forecasting how much money can be saved in value-based initiatives. But I haven't seen someone use that like to their negotiating with a local insurance company at this point.
Because when I was talking with Blue Cross, they said something funny. They said, here's our fee schedule, and we think it's very fair. And I was like, okay. Like,
based on what?
Yeah, I said, what, based on what data did you support that with? And they said, well, we just know the market, and we think what we're paying is very fair with what other payers are paying. And I said, okay, that's interesting. Let me pull up my data, and I can tell you what every payer is paying us, and you guys are number 7 out of 9 on the worst payers that we have. And I was like, here's the data. I'm going to share this with you in a PDF. Oh, and by the way, like Florida is at the bottom of the barrel too compared to other states. And I said, so I would love to hear your take on it, on why, because I'm all ears. I would like to hear you support that comment that you think it's fair. And it was pretty funny how quickly they changed their tune, and want to all of a sudden start working with you, so and unfortunately I think as an industry in general, any conversations about insurance negotiations are shut down pretty quickly, because they're afraid that we're going to collude together and say, hey, if I do this and everyone else does it, we can all go back and ask for more. And just to be clear, that's a big no-no. So definitely you definitely want to make sure you understand what we can and can't do. And unfortunately, when I reached out to the FPTA to ask them about that, they basically told me you can't talk about it. And and I'm like, well, that's not true. I'm allowed to tell everybody on the planet that I negotiated, or that I dropped Optum. I dropped Optum because they were paying me $50 flat rate per visit. That's why I dropped them. I'm not telling you to do it. I'm not telling you that we should all do it. I'm saying that.
You're not saying on June 1st we're all going to stop. On June 1st, we will all stop taking Optum for a month to show Optum to go take a hike. That would be a problem.
But it's a big deal because it's a federal law, and insurance companies will definitely, if they think that that's happening, they'll probably make sure that that they're onto you, and that they think that that's what you're doing, even if it's not true, and that'll scare the crap out of all of us if that happens to us. So I think what Strata is doing is literally the best thing you can do, is just exposing all that data. And I think if we talked about it more in an open forum about what everyone's getting paid in this, and as long as there's no context to it, then it's perfectly legal. And if we all knew what everyone else was doing, then we would, it would, right now we're falling into their trap, because I have no idea what you guys are getting paid per visit. It might be different than me. So if you haven't looked at that Strata, benchmark thing, do it for.
Yeah, we've linked that in there, and I'll link it again for everyone so they've got it. So we've got about.
Sorry.
Yeah, go ahead, Ben.
I was gonna say, Roy, I mean, being a newer clinic, like I don't know how saturated your area. I don't know specifically where in Carolina you said you were, but I don't know how saturated your area is as well. But I'll just give you a quick allegory pertinent story that you may be able to use to your advantage. Hospital special surgeries, which I'm sure we've all heard of, recently expanded into Florida. So maybe 2 years ago, they came into the West Palm area, and pretty soon, Justin, they'll be in your neck of the woods a little bit, where they're partnering with NCH.
Yeah, Naples, yeah.
And building a pretty big hospital there. When they came to Florida, they didn't have a hospital. So all of a sudden, you had this business model that was hospital, and all of a sudden they're here in Florida, and their CEO of Florida is going like, well, this is different. Like, what am I going to do to change things up? Because I can't wait for me to build a hospital, go get contracts, et cetera, et cetera. And HSS made a conscious effort in West Palm Beach to go, we will not have a hospital. And in fact, I'm going to only negotiate value-based contracts with the payers right now. Obviously, they probably call Florida Blue and they get the phone answered probably in the first ring. I'm not saying we're all HSS, but the strategy they used is, here's our data. We think we get patients better, quicker, et cetera. And we want these value-based contracts, and we will negotiate with the people like Optum and people that don't want to deal with them, and we're going to get these really cool contracts. And the parallel allegory I'm making here is, some of what we're saying is very much like in the box still, and it's conceivable that instead of getting your rates bumped up 5% across the board, if you're going like, I just want to do something a little out of the bounds or a little out of the box, or get something done different, and you're collecting all this data and you're willing to say, I am a value-based provider, that's another conversation you could have with people, is about the buzzword right now for insurance companies is total episode of care, or episode of care costing, where they want to pay you for an episode of care a flat rate. And yes, it's capitated, and I could call it a capitated market as well, but they want to do diagnostic episodes of care is a big thing for insurance companies right now. And same with primary care, they want to delegate episodes of care. So maybe it's a matter of, hey, I'm not going to look at this on a per unit basis. I'm going to look at this as, how good am I with non-operative shoulders? And I'm going to say, give me $700 cap fee for your non-operative shoulders. I guarantee these KPI metrics, 20% improvement on a SPADI and a satisfaction rating of 8.2%, 8.2 or higher in net promoter. And if I maintain these quality metrics, I then also want a 10% bump on the backside at the end of the year, at the end of the quarter, will true up. And you may go, well, $800 isn't great. It is if you change your delivery paradigm. It doesn't mean that I would recommend seeing a patient in your office 3 times a week for 12 weeks. It means doing a combination of hybrid care, virtual care, and remote monitoring and telehealth and 1-unit visits here and there. But that's something where if you're frustrated, kind of like, man, I'm just having a hard time getting on panels or getting into networks, or I'm not satisfied with the rates that are easily accessible, it's another technique you can use. And, as long as you think you've got the sophistication to be successful in that, you can be very successful in those models.
Yeah. Thank you, Ben.
I appreciate that. Thank you.
So we've got 10 minutes left here, Blaine. I know you've got one more question. Before we jump to that, does anyone else on the call have any final questions? Dustin, Elsa, Sarah, Lowell, feel free to jump in, you guys. But let's start with Blaine's question, and then if you guys have more, we can go from there. But Blaine, I think it was about AMA for Justin.
Yeah, so I'm a new clinic director. Pretty recently out of school. We really didn't. They pretty much taught us 8-minute rule and no real kind of variation. And I remember even getting into an argument with a biller before when I was doing home care, because I'd see a patient for 30 minutes and I would bill the 2 units, and they would be like, "Oh, you can get this amount." And I'd be like, "What are you talking about?" And they'd be like, 8-minute rule. And I'd be like, "Well, that's different." But so now, though, I've been hearing about the AMA rule, and I have friends who are working for bigger practices, and they had people come in and like teach them how to do it and what to look at. So basically, I just want to kind of know like which insurances does it work for, and where to look to see on their insurances if they use the 8-minute rule or if they're using the AMA rule.
So you have to look in your actual contract, and most of them will have your provider billing guidelines. It's a PDF. It's probably about 300-400 pages long, and you have to go through that PDF and see what their billing guidelines are in that specific insurance. I know Medicare is an 8-minute rule payer. It means that the total time really dictates how many units you can bill. And versus AMA doesn't have the total time requirement on there. It is if you complete more than 50% of a 15-minute unit, you can bill that unit. So 8 minutes will get you 1 unit of 97110. If you do 97112 for 8 minutes, then it's more than 50%, and you can bill 1 unit of 97112, and same with 97140, 97. You can go in as long as. Now, if you do add a second unit of that same code, now you have to complete the 15 minutes of that first 8-minute unit that you had. So and then you have to add an additional 8 minutes, which makes it the 23 minutes, which everyone knows. So if you have 2 units of 97110 and 23 minutes, and then 8 minutes of this code and 8 minutes of that code, then you could technically do all 4 units in what's that math?
32 minutes.
So it's versus 53 minutes. So you can get it done quickly.
But real quick, 2 things. Very few payers that are traditional, like commercial payers, are doing AMA right now. Another way to find out is when you check benefits, you can ask, do you follow Medicare rules for billing? They'll say yes, which means it's 8-minute aggregate. The other thing I'll just quickly say is there's plenty of circumstances where if you boil down a bunch of different billing scenarios, there's times where the Medicare billing scenario actually favors you more than the only time the AMA really favors you if you're doing like 4 distinct units, short times, like you got a cool little thing going on there. But with Medicare, you've got that overflow of 1 unit that helps populate the other unit, and you lose that on the AMA.
And so that's one thing with Medicare rules that a lot of PTs don't understand too, is you can, just because you did 5 minutes of a specific code doesn't mean you have to do 8 minutes and bill for that code. You can do 3 minutes of it from a manual therapy code and not bill manual therapy, and you can still use that 3 minutes towards your aggregate to get the total time in. But I would say I think Ben, I think if you ask people, do you follow Medicare's billing rules? I think a lot of people, especially if you're talking to like a customer service representative, a lot of them will say yes.
Yeah,
they'll default to it. But if you actually get into the contract, you might find that there's no mention of actual those billing for time units billing, and they'll actually reference AMA in there. And there's those contracts are not perfect, and there is stuff that's not defined in there. And if you ask them to define it for you, you might not get the answer you want. So sometimes the question is, do I ask every question, or do I use my judgment and do what it says word for word in their contract? With RTM, we're dealing with that too, because RTM is something new, and there's a lot of undefined things with RTM right now that if you maybe next month they'll come out there and say, oh, just for clarification, what we meant is this more specifically, and then we have to follow those rules. But as of right now, there's a lot of gray areas. There's a lot of gray areas with the CPT coding. Our CPT codes are like a Venn diagram, and they kind of overlap each other, and it depends on what the intent is, but you talk to 10 different therapists, you'll get 5 different answers on what to bill. So ultimately it's your decision when what you think's best.
Awesome. All right, well, we've got a couple minutes left here. We'll give it a sec if anyone's got any more questions. If not, Justin and Ben, any final thoughts or any words of advice for everyone on the call, just as far as reimbursement goes, or anything else we've covered today?
My word of advice would just be that sometimes taking a patient for a loss, or what you think that you can't turn them down, so you have to take them because you feel like your schedule needs to be full. Spending time on something that isn't making you money is just an opportunity that you could have been spending your time on something else to build your business in a better way to make more money down the road. So just because you're busy doesn't mean you're running a good business. And that's one thing that's kind of a hard lesson that we all kind of have to learn. But we feel super busy and the profits aren't there. It's probably a good indicator that you need to take a more deeper dive into your payment profile.
I'll leave something with a controversial subject. I kind of like drop the mic, and I guess we could take people yelling at me later, and then and just dive into this deeper. Is I would seriously question the paradigm of a 4-unit visit, and I'd start highly encouraging people to start thinking about a 2-unit visit, and what it does for your practice is pretty. Assuming that you're understaffed and you have business to get in the doors, where maybe if you're a brand new clinic and you don't, then maybe I'll say start at a 4-unit visit. But I would highly encourage someone to start doing the math and economics and all the trickle down of a 2-unit visit, what it does to your practice.
Awesome. Well, thank you everyone for being here. We're going to continue to do these office hours each month. If you enjoyed this one, please send us a note. Let us know if there's something we can improve on. Let us know as well. If you want to chat with Strata, check out our EMR and RCM. Feel free to go to stratapt.com and go from there. But other than that, we will see everyone next time. Thanks for listening to another Strata Office Hours. Strata is a single EMR platform and revenue cycle management service for physical, occupational, and speech therapy practices that helps you achieve a 99.99% reimbursement rate. If you'd like to learn more about Strata and see how our EMR and RCM works, head over to stratapt.com to book a demo.